Can you see the full screen?
Yep, we can see everything. Thank you.
Great. So it's a real privilege and honor to be presenting to you. I was told that I need to wrap up the guidelines in 15 minutes, which is like totally impossible to do because these guidelines are incredibly extensive. They were very ambitious, and those of you that were on the guidelines development group with me, you know that, I mean, it took, I think, 4 or 5 days of 6-hour days of the group working through all of these issues. So it feels very monumental, all of the changes that happened with this guidelines. And I'm actually going to have to focus more on some of the clinical aspects just for the sake of time, and then hopefully we can have discussion later on. Before I get to the guidelines, I just want to call your attention to another kind of major publication that came out from WHO. This comes out about every couple of years, and it's really the best update that we have to the global epidemiology of hepatitis, as well as was mentioned in the introduction, I do some work with the Clinton Health Access Initiative, and we are very concerned with access to drugs and diagnostics, and some of that is in this global hepatitis report as well. So I'll put the link in the chat a little bit later, but this is a great report in terms of updating your epidemiology. One thing that's a little bit strange is sometimes you see the global estimated number of people living with hepatitis B can vary or fall, and that's just because the epidemiology is getting better. Not that there's millions of people that are suddenly not diagnosed with hepatitis B, but the number actually the estimate has fallen a little bit. But highly encourage you to take a look at this because it does inform the guidelines and the global situation as well. So this is derived from that report, and the number in 2022 of people that are estimated living with hepatitis B globally is 254 million. That's of course a drop from the 2019 report of about 50 million actually. But I think what I wanted to highlight here is just the regional variation of people living with hepatitis B, and then the ongoing crisis, I would say, of ongoing infections and deaths from hepatitis B. What you can see here is there's really a dominance globally of Asia and Africa in terms of making up the millions of people that have chronic hepatitis B. The African region was 64 million estimated, and then the Western Pacific and Southeast Asia with almost 150 million people. Very different situations on the ground in those different countries, and I'll talk about some of the heterogeneity as we go. There's also over 2 million new infections per year and over 1 million deaths per year when you combine hepatitis B and C. So clearly we're not quite there yet in terms of controlling these diseases and eliminating mortality. And then, of course, the overall goal here is to eliminate hepatitis B and C by 2030, and we have a long, long way to go. Just as a footnote here, I also put hepatitis C prevalence here, which also appears in this report, 50 million globally. And then kind of the new kid on the block, which really shouldn't be the new kid on the block because it's so much more aggressive than hepatitis B or C, but hepatitis D or Delta. There's some significant sections in the WHO guidelines about testing for Hep Delta, and it is estimated currently that there are 12 million people in the world living with hepatitis Delta. Now, also in this report is how we're doing so far, and I'm just very ashamed and embarrassed to present these numbers globally. It is believed that only about 13% of those 254 million have actually even been diagnosed with hepatitis B. So when you think of the cascade of how we get people from a diagnosis all the way into effective treatment, there is a long way to go, starting with testing a lot more people. So the global number here, which you can see, let me get my pen, there we go. So globally here, 13.4% are believed to be diagnosed. This is a slight improvement from the previous report in 2019, which was 10%. So a little bit better. I think that might have actually occurred just because the denominator was adjusted, unfortunately. And then the number that are on treatment is now about 2.6%. Overall. So this obviously, when we have 1 million people per year dying of hepatitis C or hepatitis B and C related complications like cirrhosis and liver cancer, and only 3% of people are on therapy, there's just a lot of work to be done. You can see lots of regional variability as well. And on this slide, as well as several others that I'll show, it's really the African region that stands out. Just only 4% of people with hepatitis B believed to be diagnosed in Africa. The next slide, I think also, I have to hand it to the WHO. They're calling this out as a major barrier to getting to elimination, and that is the situation on the ground in the African continent. So 4.3 million pediatric infections, and 70% of the new infections are occurring in Africa. And the reason is because we have very effective vaccines against hepatitis B, and both a pediatric and a birth dose scheme that can nearly eliminate mother-to-child transmission. And many regions of the world have actually succeeded in implementing these types of programs and really achieved the global goal of childhood control, which is defined as less than 1% Hep B surface antigen positivity in children under age 5. If you look at this chart here, the other regions of the world, these are all the WHO regions if you're not familiar with these abbreviations, but the Eastern Mediterranean, the European, Southeast Asia, Western Pacific, and then Pan American, all below 1% in terms of the surface antigen level for children, and that actually makes the global level less than 1% as well. But Africa is really an outlier here, 2.3% positivity, and that's just no secret. It's because birth dose vaccination has really not been widely implemented. A lower percentage of in-facility births that are attended as well makes that very, very difficult. Now, there's some movement globally that looks good. Gavi, which is the major funder of vaccines, has sort of signed on to increase birth dose vaccination. But we have a new tool that's antiviral therapy, and that is addressed in the WHO guidelines. So that's sort of setting the stage. Let me just sort of outline what these guidelines do, or what they try to do, and what their priority areas are. I should say that these are a little different than other guidelines that we're used to seeing as clinicians, such as APASL or EASL or AASLD, which tend to be much more high-income country focused, very clinically oriented to answer all those clinical questions. WHO guidelines, as it says in the box at the bottom, are really, to target national hepatitis program managers, and really especially focusing on lower and middle income countries. And in my view, just to say it, these are really trying to give us a minimum standard of care that all countries, no matter what their health budgets are, can adhere to. The main priority areas, as I mentioned, were to expand treatment eligibility for adults and adolescents, to use new non-invasive test thresholds. It sounds kind of not too exciting, but it is a real game changer in terms of who qualifies for treatment. And then it allows us to more easily diagnose fibrosis and cirrhosis in environments where we don't have things like ultrasound or FibroScan. There's a major section about expanding antiviral prophylaxis for hepatitis B surface antigen positive pregnant women that addresses this major problem with mother-to-child transmission. And then there's other areas that I'm actually not going to have time to talk about today, such as HBV diagnostics, using point of care, HBV viral load, reflex testing, testing for hepatitis delta, and so forth. And then aside from sort of the evidence-based guidelines, there's a whole large section on service delivery and how we can sort of move qualitatively more towards primary care-based hepatitis B treatment, or at least differentiated care, where sort of the sicker patients go to the specialists and people that are relatively stable go to their primary care or whatever healthcare they can access. Now, just one slide to show you what a major undertaking this was. It's been basically almost 10 years since the last major clinical guidelines from WHO, and there's been a lot of work done. So 15 different systematic reviews done really all over the world, different university partners that did those. A lot of modeling work that was done in terms of the proportion eligible and how this would impact health systems. CHI actually participated in some landscape analysis of diagnostics and costs and access to treatment. And then something that's really a hallmark of WHO guidelines is there's an acceptability, values, and preferences surveys that are incorporated. So asking affected people what they think of these guidelines. And I have to say, and maybe Michael will agree with this was the patient advocates that were on the guidelines development group really provided a very different environment in terms of talking about treatment eligibility, people demanding to be treated, whereas the previous guidelines really did not recommend that they would achieve treatment. The guidelines themselves really address or attempt to address all elements of the cascade, from testing to confirmation of diagnosis with viral loads, to linkage to care, to treatment, and then of course the end section on simplified service delivery models. And as I mentioned, the main areas of focus were PMTCT, diagnostics, the liver staging and non-invasive assessment, and then the simplified treatment criteria, treatment, the drugs themselves, hepatitis delta, and service delivery, way more than I can talk about in the next 10 minutes. So I'm going to focus on kind of these middle ones, which are more clinically relevant. You're probably familiar with the old guidelines, last released in 2015, which is, again, a long time. And these at the time were innovative, I think, but I think the WHO, maybe not publicly, but privately, acknowledges that these guidelines have essentially failed to be implemented. And when you see only 3% of people being treated, I think there's a couple of reasons for that. Number one, these guidelines really favor not treating. If you look at this guideline algorithm itself, the majority of the space is taken up by this, which says defer treatment. And so if you're not above age 30 with persistently abnormal ALT and a high viral load, the guidelines are saying don't treat. That's the first thing. Secondly, many countries are not able to widely make HBV DNA available. And so these just really, I think, failed to get more people on treatment, and the WHO, at least privately, acknowledges this. There's a couple of really important points that I've highlighted out here in the table, which is that viral load thresholds in terms of who to treat really are focusing on those that have cirrhosis with an APRI score threshold of 2, which is really quite high. And it's going to miss a lot of people that may have near cirrhosis or advanced fibrosis. And then the HBV DNA threshold of 20,000. Again, if you don't have HBV DNA available, you're never going to even get that test. And so people, quote unquote, won't qualify. Let me move forward. And eventually I'll show you the new algorithm, which looks a whole lot different than this one. So I'm going to start with liver staging. And again, this sounds kind of boring, but it's really, really important. And here's the updated recommendation and then a new recommendation as well. The first thing is APRI. We should all be talking about APRI. We should all know what APRI is. We should actually have our patients know what APRI is because it's cheap and it's available, and it's actually one of the qualifying criteria to now qualify for treatment on these guidelines. The APRI is basically something that you can get with just a simple AST level as well as platelets. So 2 widely available tests that can be put into a calculator that sort of gives you an estimate of the likelihood of cirrhosis or advanced fibrosis. Transient elastography or FibroScan is probably a little bit more accurate in terms of sensitivity and specificity, but really it's an expensive machine and not available everywhere. So that's fine if you have it, but really not required. The new recommendation here on the bottom, which is very important, is that whereas you used to have an APRI score of 2.0 or higher to technically qualify for treatment, this has been dropped significantly to 0.5. And essentially, the risks and benefits of overtreating or undertreating were debated fiercely by the guidelines development group. And many people believe that, setting that threshold too high is going to miss too many people.
IT, that's all I know.
If you could mute, please, that would be great. Thank you. And really, this is a much more inclusive threshold. And the only people that are going to be actually excluded based on this are those with really no chance of cirrhosis, no evidence of advanced fibrosis. Of course, these are not perfect tests. They're not, ultimately sensitive and specific. I'll show you that on the next slide. But really, taking everything into consideration, the guidelines development group really wanted to drop that threshold as much as possible. And then there's also lower transient elastography thresholds that are mentioned here. Anything above 7 kilopascals, if you do have that available, is recommended as sort of considering that F2 fibrosis or greater. Here's just a couple of the technicalities in terms of the numbers. Using that lower cutoff, the sensitivity is greatly improved in that APRI to about 70% in terms of picking up people that are F2 or above. Even just going to an APRI cutoff of 1.5, your sensitivity goes way down, even though the specificity is improved. And what that means is we're willing to tolerate more false positives with this test, and we're less willing to tolerate false negatives. We don't want to leave people behind, and it was felt that the prior cutoff that was very high was doing that. Just a note on the bottom here that there's less evidence of APRI scores in large cohorts of adolescents, but the guidelines development group felt like because a lot of pregnant women are actually adolescents themselves, and pregnancy and prevention of mother-to-child transmission was a major focus of this guideline, it was felt that it was more important to just sort of extrapolate the adult data to kids. And so here it is, just one more time, the existing recommendation and the new recommendation here, that 0.5 is the threshold for APRI for qualifying, or a FibroScan of 7 kilopascals or greater. This is a significant drop in that and it should be more inclusive. And this was really chosen to only exclude those that have basically no fibrosis at all. Okay, moving on to the simplified treatment. This is really the beefy part, or the main part, that I think is going to change our clinical decision-making. And really what the WHO has gone with is, instead of having, basically that large section that is all about excluding people, it's sort of a pivot and a change in posture here. There are 4 different criteria, only one of which depends on the accessing HBV DNA testing to quote unquote qualify. And these are going to actually go from, I think the original guidelines from 2015 only recommended treatment for about 8 to 15% of the global population with hepatitis B. And it's estimated, based on some modeling work I'll show you on the next slide, that these 4 criteria are now going to capture over 50% of people with hepatitis B. So the first one I mentioned is any significant fibrosis, F2 level or above, based on an APRI score of just 0.5 or greater. And that is going to probably capture at least a quarter of people that are surface antigen positive. The second is an HBV DNA above 2,000. If you remember from the 2015 guidelines, that was 20,000. And an ALT level above the upper limit of normal, which is considered in these guidelines to be 30 and 19. I have to always switch in my head because AASLD typically uses 35 and 25, but WHO went with 30 and 19. And in adolescents, there is one little caveat here, that it should be at least 2 occasions, just to be extra sure before we put an adolescent on a potentially lifelong therapy. That's again going to qualify about 20 to 35% of people that are surface antigen positive. These are overlapping groups here, by the way. The third and fourth are interesting categories where any co-infection, such as HIV, hepatitis delta, or hepatitis C, any family history of liver cancer or cirrhosis, any immunosuppression, or comorbidities such as metabolic associated steatotic liver disease, or MASH, or extrahepatic manifestations. All of these things will sort of allow a clinician and a patient to decide together to go ahead and start therapy. And then in places where HBV DNA is not available at all, if all you have is an ALT, a persistently abnormal ALT is going to qualify someone to be on treatment. Of course, this might result in some overtreatment if somebody has fatty liver or alcohol use or some other reason to have abnormal ALT. But the guidelines development group felt like these patients are the ones that are going on to develop cirrhosis and liver cancer, and they should have the opportunity to be treated. So a little bit of the modeling on the impact of these changes. This was done on cohorts in Ethiopia and Pakistan and presented to the guidelines development group. Based on different scenarios, different cutoffs of ALT and of DNA, it's looking like at least sort of close to 50%. And again, these are not mutually exclusive categories, but when you make things a little bit more inclusive, we're looking at more than 50% in some cohorts that are going to quote unquote qualify. This is all based on evidence because the WHO guidelines really follow strictly the grade methodology. And you can't just say, I want this to be the recommendation and argue about it. You have to have evidence. So many systematic reviews were done. I'm going to show you very briefly 2 of the big ones. And then lots of modeling to see who is going to qualify. And then they actually ultimately decided on the number needed to treat to prevent 1 case of liver cancer, because the data is never as ideal as we want it to be. Very, very long-term, large cohort studies of people with low viral loads or normal ALTs with like 30, 40 years of follow-up. We just don't have a lot of that data. What was done is this systematic review on the natural history of liver-related deaths, liver cancer, and cirrhosis based on viral load levels and based on ALT levels. And what you can see in this is that if you were to use just the threshold of 20,000 and above, sure, you have a really marked increase in death, marked increase in liver cancer, marked increase in cirrhosis. But what about this category of 2,000 to 20,000 in gray here? We're sort of missing a lot of people that are dying of liver-related consequences, getting liver cancer, and getting cirrhosis that were really missed by the prior guidelines. Some people in the guidelines committee argued, well, look at those lower thresholds, even below 2,000 or below 200, you still have a greater than 0 or a non-zero impact on all these outcomes, but it was felt that the evidence wasn't quite strong enough. Same thing with liver function tests, or ALT level over here on the right. If we go to 2 times upper limit of normal, which was sort of the previous threshold, yes, we have much, much higher rates of cirrhosis, liver cancer, and death. But even just a little bit above normal, or 1 to 2 times the upper limit of normal, this orange, a marked increase in liver-related deaths, liver cancer, and cirrhosis. The second systematic review was looking at antiviral therapy. So what evidence do we have that treating people in these different categories actually makes a difference? And I know there's a lot of information on the slide. I just want to focus in on the number needed to treat table, which is on the bottom here. And it was decided that really when you use the lower viral load threshold of 2,000, the number needed to treat to prevent one case of liver cancer is 210, one case of cirrhosis is 137, and then a liver-related death is 1,000. This is sort of the balance of risks and benefits, and the evidence was felt that it's worthwhile to treat 200 people to prevent 2 cases of cirrhosis and 1 case of liver cancer. So putting the two side by side, and I'm almost out of time here, we've gone from really what I would say is rather exclusionary process or algorithm where a lot of people were not qualifying and really told by their doctors that they shouldn't be on therapy, to really more of an inclusive guideline where you have 4 separate areas where people can qualify, only one that depends on viral load, others that depend on fibrosis assessment with a simple measure such as the APRI score above 0.5, and then other comorbidities or persistently abnormal ALT where you don't have DNA. I am going to shoot through very quickly the antiviral therapy and then just a brief word on PMTCT at the end. There's been some slight adjustments here, which are kind of interesting. So we all know that tenofovir and entecavir are really the first line and preferred regimens, but there's been an interesting economic situation happen, especially in lower and middle income countries that are rolling out HIV PrEP or pre-exposure prophylaxis. And that is that a single pill of tenofovir or entecavir in many cases is actually more expensive than a combination pill that has tenofovir and lamivudine or tenofovir and emtricitabine in it. And that is because the market forces are very different when you have big, large bulk buying of combination products such as TDF3TC or TDF-FTC, you can get lower prices. And so Chai contributed a lot of the data to this. Essentially, you're not going to do additional harm by treating somebody with a 2-drug regimen compared to a single drug regimen. And so the guidelines basically said, look, you should go with whatever's available and whatever is cheaper in your country. And the prices here are, a couple of dollars per month, really, to pay for generic versions of these drugs. And so it should not be much of a barrier for ministries to take on this new therapy. So the new recommendations here are that you can use combination products if you want to. That was updated. And then also a little bit of a comment on TAF or tenofovir alafenamide, not as a first line, but is sort of recommended if there is established osteoporosis or impaired renal function. All right, final words on PMTCT, and then I'll give it back to our panel. So we have guidelines that were published in 2021 that do recommend antiviral prophylaxis with tenofovir starting in the 2nd trimester for women who have viral loads above 200,000. And that threshold was chosen very carefully because if a woman has a viral load below 200,000 and has access to other measures of prevention, such as birth dose vaccine, there really isn't any transmission, literally 0 in one of the systematic reviews. But these guidelines probably weren't implemented very easily because it does take a lot of logistics and availability for a woman to come in early for prenatal care, get a diagnosis of hepatitis B, have a viral load sent, have those results returned back in time in the 2nd trimester to actually start antiviral prophylaxis. So the availability of Hep B DNA really impaired implementation of these guidelines. So the new guidelines, consistent, keep this recommendation of if you have DNA available, sure, you can offer antiviral prophylaxis to women above 200,000. But if you don't, you can actually go ahead and offer antiviral prophylaxis to all surface antigen positive women. So again, an acknowledgement that HPV DNA is not available everywhere. You should preferably start in the 2nd trimester. And this is a very, very effective intervention. Obviously, it should be used with other interventions like birth dose vaccine. But if birth dose vaccine is not available or is not offered in a timely manner, this antiviral prophylaxis should prevent more babies from being infected with hepatitis B. Now, there's a little footnote here, which is very interesting and was very controversial in the guidelines development group, which is, what do you do after delivery? Do you stop that woman off of her tenofovir or TDF because the pregnancy is over? Well, if a woman is planning on being pregnant again, there is an option to leave that woman on antiviral prophylaxis in sort of an option B plus scheme. If you have followed HIV treatment, what happened in Malawi is when there were variable thresholds of who qualified for antiretroviral therapy, the country of Malawi kind of thought they would do something progressive and say, look, all pregnant women can take antiretrovirals for prophylaxis and then just continue on them. And that is in these guidelines, which will allow ministries of health and national guidelines in country to say, look, women of childbearing age, we should just keep them on therapy, whether or not their own liver disease qualifies them on the original criteria for the purpose of mother-to-child transmission prevention, as well as preventing them from going on to suffer liver consequences. We should allow them to just continue on. I'm going to skip over this because I think I'm out of time. And just final slide here on this is not, the PMTCT recommendations should not be taken in isolation. We obviously need to increase Hep B birth dose vaccination. The new Gavi eligible countries support should be helpful in that. There's a big move to do triple elimination of not just HIV, but hepatitis B as well, and syphilis, mother-to-child transmission of all three. Of course, we need increased healthcare work capacity to get this all done. And then we should be simplifying and integrating and not be so vertical in our approach to all these three different things. All right, so I went a little bit over, I apologize, but thank you for your attention.
All right. Thank you so much, Dr. Rimmers, for that wonderful presentation. If anyone has any questions, you can put them in the chat or come off of mute or raise your hand.
I had a few questions, if possible. Thank you so much for that overview. So just a few questions in no particular order. One is the ALT elevation. I'm a little bit surprised that that made it into the World Health Organization guidelines, because really I feel like in the field there has been a movement away from ALT elevation. I know you showed the data that it is associated with outcomes, but when comparing it with the HBV DNA level, does it really provide additional prognostic value? That's one. Another is in the guidance, any consideration for family history of HCC, genotype in terms of recommendation for treatment. And the last one is, I saw that in one of the 4 main recommendations, it recommends treatment of patients who are co-infected with HDV. And that's also kind of contrary to what we typically recommend, because nukes don't really work for HDV. So I'm curious about that recommendation as well.
Thanks for the question. So first of all, let me tackle the easy one first. Genotype, there's just not availability of genotype in most of the world. So that's not going to make it in there. Remember, these WHO guidelines are really focused on lower and middle income countries. So that's just not even part of the conversation at all. The second was about combining
and
the
family
ALT
history, the family history along with it.
Yeah, so family history is in there. Let me actually show my screen again. So this one here, recommendation number 3.
Oh, I see it. Oh, sorry, missed that. Okay, thank you.
So great idea, Tatiana, and that made it in there. In terms of the co-infection, I think that you're right that Hep C, of course, it's a different disease, but they wanted to be very inclusive and just sort of get more people in and make it. And then it's really hard for WHO to make things simpler with all of these different things. In my view, this is really not a simple guideline. Simple would be test and treat, or something like the Chinese government has done, where you're over age 30, you have virus, you get treated, period. And that's not really the approach. I feel like our hands were tied by the grade methodology. They really, really adhere to things. And I will tell you some inside information. The guidelines actually were rejected twice by the oversight committee, because a lot of what the original GDG wanted to be put in there was not evidence-based enough for the oversight committee to actually. So believe it or not, these guidelines were submitted and they got a revise and resubmit from the oversight committee of WHO. So that was one of the points of contention, I think, actually, that you brought up in terms of why can't we just have DNA period and no ALT? And there was something about sort of the way the evidence was laid out in the systematic review that the oversight committee did not agree with.
And then just one last thing, the age, there's no mention also of age over 30 or anything. So that's not a consideration at all here.
That's right. And that was to sort of, it's a really difficult thing to include guidelines that apply to the whole world. And I mentioned in my preamble part that really a big focus of these guidelines was adolescent women of childbearing age and how we can be more inclusive of them. So I think it was felt that having an age cutoff of 30, the way the previous guidelines did and the way the Chinese guidelines read, might leave room for clinicians not treating more young women who are actually having babies. So that was removed completely. It doesn't show up in the algorithm at all.
Great, thank you. And just one very last quick question there. Obviously, I'm assuming there's no recommendation for stopping therapy at any point. Maybe that's not in the main guideline, but that's somewhere, or it's pretty much once you go on indefinite.
Yeah, certainly during the GDG meetings, there was not time to address that question, and it was not one of the major PICO questions. So if I remember correctly, I think they left it as it was in the 2015 guidelines. Which I believe says, presumptively lifelong therapy, and then in a certain subset on a case-by-case basis, you can consider discontinuing after seroconversion.
Got it. Great, thank you.
Dr. Reimers, that was fantastic and really a wonderful overview of this exciting change. I wonder, can you comment on any guidance or any comments that the guidelines have provided with regards to implementation and sort of how these new recommendations are planned to be disseminated throughout the world, and sort of any caveats there that we may find limiting implementation of these recommendations?
That is an incredibly important question, Jesse. So thanks for bringing it up. I could go on for an hour about how worried I am that these are not going to be fully implemented, mostly for financial reasons, actually. Anybody that works in the global health space knows that there are several diseases that are very privileged. And it's mainly HIV, TB, and malaria, because we have this thing called the Global Fund, and we have something called PEPFAR that have billions of dollars that have been pumped into global health, and viral hepatitis is just not on that map. So look, the last 10 years of my work on global hepatitis has been trying to get pots of money pulled over from those three big ones over into viral hepatitis. And I am very concerned that ministries are going to look at this and say, well, how in the heck are we going to pay for this? So that's a major problem. I think the fact that the drugs and the diagnostics are getting very, very cheap for hepatitis B is a good thing. Less than a couple bucks per month really gets us to the point where a lower middle income country really could afford to put their population on antiviral therapy and prevent the death and liver cancer and cirrhosis going forward. But I will say with reluctance that WHO doesn't have really a plan for funding all of this. There's lots of activity, including this webinar, including a one that WHO did on Monday. Chai is going to do some stuff. And I think WHO is really depending on its partners to get the word out and to explain these things and to disseminate the information and then hope for the best in terms of implementation worldwide. But the real problem in implementation is that we don't have a large funding body like PEPFAR, like the Global Fund, that is going to power these guidelines. It's going to take the sort of ground level hard work that all of us are going to do from here forward. One last comment on that, Jesse, is that there is a section at the end of these guidelines that is all about service delivery considerations. And so, there is kind of a well-informed discussion of differentiated care, as I mentioned, primary care, telehealth programs like ECHO, different ways that have been shown to basically have good high quality care in different models of care. Obviously, it's the World Health Organization. There's 1,000 different ways to do this, and they do a lot of discussion about that. And it's very consistent with previous HIV guidelines and previous hepatitis C guidelines, and that the move really is to task sharing or task shifting, integration with other existing programs, and decentralization.
All right, thank you so much. If there are any other questions, feel free to put them in the chat. I do have one comment or question about the funding aspect of this. So I spoke to a professor at UAB who works in Zambia, and he was part of this project. He worked in the HIV space. but he was part of this temporary project where they were able to get access to medication for hepatitis B patients, even those who were not co-infected with HIV. So what are your thoughts on maybe integration within the HIV space if we don't have enough funding solely just for HBV, but we can maybe integrate within these global HIV spaces and make it more accessible, or make it medication and treatment more accessible and available?
Anusha, that's a great example. And look, everybody in hepatitis has been doing anything they can to get funding. And the fact that there are many patients that are co-infected with HBV and HIV, or HCV and HIV, has been a way to leverage those HIV-related funds. The HIV folks don't love it because they feel like it's mission creep, and they still want to keep this exceptionalism, and they want to enjoy the funding that they have now forever. But I think there's really not much of an appetite anymore to do additional vertical programs. The example that you've given is actually how hepatitis B treatment has happened globally. And that's great for those people in Zambia that benefited from it, but it's not a solution. Going after a little grant to sort of do one thing on the back of an HIV funding program, that's not going to do it. We really need sort of more of a global comprehensive approach where this is considered part of basic primary care or basic human rights from even the lowest income country. And again, I mentioned the fact that the drugs are so affordable now. There has been a little bit more noise from the patient and advocate community saying, like, wait a minute. There's actually one very, very key point in the guideline development group that I had Sue Wang actually brought it up, and I had a light bulb moment where they were talking about, there's some old school hepatologists that really still think the older guidelines are the way to go, where a lot of people don't need to be treated. We should be excluded. There's not enough evidence to do test and treat. And we brought up this idea that, look, if you are in Africa and you are at risk of HIV, you are getting PrEP medicines thrown at you. There's all kinds of programs because of this really well-funded HIV prevention program, and HIV has just had such good funding. Think about it. Somebody next to you who says, I'm having sexual risk of HIV, and they get, TDF-FTC or TDF-3TC, basically government sponsored. Someone standing next to them with an HBV viral load of 1,000 or maybe even 15,000, if this was the old guidelines, is told that they can't be treated for a disease that they already have, and that may cause liver cancer in them in the future. So that moment, I think, changed a lot of minds to think, like, what are we doing here, where we're giving out HIV prevention to people that are healthy, and we're not giving HBV treatment to people that have a virus that could potentially kill them. So I think that really opened things up a little bit more. And again, the driver of all this is that these drugs are now generic and affordable and should be available. And if the patient and advocate community makes a little bit more noise and demands it as a human right, I think that's going to make progress country by country.